And firstly, let's start with short presentation. It will take around 10-15 minutes. And starting with our approach, our result, our perspectives. And three important positions we will discuss in the end of this presentation. Three important questions and our answers. So the topic of our webinar is autologous hematopoietic stem cell transplantation for multiple sclerosis in Pirogov Center. New results, new approaches, and our future directions. So, as you know, the idea of transplantation for multiple sclerosis and for autoimmune disease to stop autoimmune process. The problem of multiple sclerosis is immunological mistake. Our immune system traditionally works protecting our body from enemies like viruses, bacteria. In case of autoimmune diseases like multiple sclerosis, immune system makes a mistake and produces aggressive, autoaggressive T and B cells. And the idea of transplantation to use high-dose chemotherapy, to use high-dose immunosuppressive therapy to remove autoaggressive immune system, so the same to remove the disease, and to rebuild new immune system using patient's own stem cells. This is a kind of new but old program, and it's still very promising approach. Effectiveness of this program is around 70 to 90% depending on the approach. It's true to say that some old protocols are very toxic, so this is why it's very important to find the best balance between effectiveness and toxicity. So, and this is what I am going to explain. The core target of transplantation is autoaggressive groups of T and B cells. Transplantation removes these autoaggressive cells, so removes the disease. And some what's about history. Why we started this treatment, why hematologists all around the world started to use transplantation for multiple sclerosis. Firstly, this treatment approach was developed to treat out hematological diseases like blood cancer, like leukemias and lymphomas. It's true to say that blood cancer is also immune system disorder. It's kind of cancer of immune system, very fatal and aggressive disease. And to save these people, doctors develop approach based on high-dose chemotherapy because we had to remove malignant immune system. It was a kind of accident when doctors started to treat blood cancer patients using transplantation. But some patients who had leukemia and autoimmune diseases, after successful treatment of leukemia, stopped with multiple sclerosis. So it was amazing accident, which was a background for lots of research, clinical trials, animal models, and first transplantation in Europe and the USA were provided in 1997 and 1999. We started our program in Russia in 1999. So you can see that multiple sclerosis is the most common disease when we use transplantation. And European bone marrow transplantation registry, there is an information about more than 2,000 transplantation for multiple sclerosis. This is the first place among all autoimmune diseases. In our university hospital, in our department, we provided more than 2,200 successful transplantation for different types of autoimmune diseases, mainly for multiple sclerosis. Also, we treat, like you can see on this picture, another autoimmune diseases, of course, much less because these conditions are much less common, a kind of rheumatic disease, rare neurological condition, stiff person syndrome, vasculitis, and other autoimmune disorders. But on the first place is multiple sclerosis, but like the most common autoimmune disease for using transplantation. And I would like to show you our recent results. Recently, we analyzed more than 700 patients with different variants of multiple sclerosis. The patient characteristic is presented here, so we included as relapsing remitting multiple sclerosis as secondary and primary progressive, very aggressive variants. So we started with a BEAM-like program. It was our first program from 2005 to 2009. It's a little bit less effective, more toxic program, so this is why we developed our protocol to cyclophosphamide-based. We used from 2009, and from 2020 we have been using fludarabine-based protocol, analyzing, comparing all these programs based on toxicity and effectiveness. So, and you can see on this diagram evolution of developing of our program and key points when we improve treatment. Firstly, we stopped to use chemotherapy for stem cell mobilization. We use only stimulating factors and steroids. We stopped to use very aggressive and dangerous myeloablative protocol, and we switched to high-dose immunosuppression by lymphoablative protocol, which is the same effective but much, much less toxic. Cyclophosphamide and fludarabine-based. Also, we stopped to use ATG. Many patients ask me why we stopped to use ATG. Firstly, ATG is very toxic. It causes lots of immunological problems. But the most important reason is Epstein-Barr virus reactivation and increasing risk of MS relapse after transplantation. So this is why we use rituximab. So good supportive care during immunological and hematological recovery, new approaches for early and late post-transplant rehabilitation. And you can see our new lymphoablative protocol based on fludarabine. This is 6 days protocol. First results show that this program is very, very effective, and this program has the safest level of toxicity. This is the safest program for today. So you can see it here. Fludarabine-based program has much less risk of hematological and non-hematological toxicities. Zero transplantation-related mortality rate. Unfortunately, we had some cases of mortality, so this is why we developed new approaches to find the best balance between effectiveness and toxicity. And you can see our results. We found that index of disability, DSS, improved significantly in patients with relapsing remitting, primary and secondary progressive MS. Also, we found that event-free survival, so this is the same as success rate in relapsing remitting multiple sclerosis, is 90%, a little bit more than 90%. Also, we found good results for primary and secondary progressive variants, 73 and 75%. Of course, to compare with remitting variant, it's less, but it's still very good result. Analyzing some factors, actually, you can see we didn't find any differences in effectiveness comparing different protocols. But of course, on the first position is safety. But fludarabine-based protocol, recent our latest statistics, seems to be a little bit more effective. But future will show. Also, we found that patients younger 40 years old had a little bit better results. And patients with shorter disease duration had better result to compare with a longer disease course. So it explains why we need to do this treatment as soon as possible. The same is about people who had intensive previous treatment. You can see that patients who had intensive previous treatment using disease-modified drugs had worse result to compare with treatment-naive patients, to compare with patients who didn't have treatment before transplantation, I mean disease-modified treatment. So this is second very important position to have transplantation earlier. maybe the variant of first-line therapy after initial diagnostic. And also, our conceptual approach is to provide transplantation in the beginning of multiple sclerosis. This is concept of early transplantation. Second approach is conventional transplantation, when we give this treatment when patient fails traditional treatment. This is indication in many clinical trials, and very rare group of patients, very difficult group, salvage transplantation, very disabled persons with high MS activity and high disability level. Of course, we need to help these people to stop MS in very advanced stage, and we can see results here. Early transplantation has the best results, more than 90%. To compare with traditional transplantation, closer to 80%, and salvage transplantation. But for very difficult group, for patients who don't have any other chances, 50% success is amazing result. Of course, future will show, maybe we will develop more effective treatment. We are developing these programs. And also quality of life in whole group of our patients improved, like physical functioning, emotional, general health, social, emotional, mental health improved significantly in 1 year and later. So it's also very good result and support of this approach in multiple sclerosis patients. So analyzing our big group of patients during long-term follow-up, we found that the best factors associated with success of transplantation are early transplantation, remitting variant, absence of disease-modified drug before transplantation, younger age, and better physical conditioning before transplantation. So preparation for transplantation is also important. And we started our activity in Moscow in 2005, and we started our department. In the next year, we will celebrate 20 years of our activity, and you can see our lessons from our almost 20-year experience. This is lessons to provide the best treatment, to provide the safest treatment, and lessons based on our 2000 transplants experience. And first one is very important comprehensive pre-transplantation examination. It's important to provide this treatment in centers like university hospital, to work in cooperation with different specialists, with cardiologists, neurologists, with physiotherapy, with intensive care unit departments. Firstly, we need to assess patients' general health, to assess neurological situation, to analyze all risk factors, to try to analyze, to predict possible prognosis, success rate, and possible risks. Of course, we should make our decision together with patients and patients' families. It's very important. Preparation to transplantation is extremely important. This is an infection screening, and this is infection treatment, symptoms control, and work in university hospitals is very important here. We provide our transplantation based on our concept, early, conventional, and salvage. And during transplantation, it's very, very important to control all positions, to provide the best supportive treatment, from timely diagnosis of complication to prevention and treatment of possible complications, psychological support, physiotherapy during isolation phase, especially in disabled patients, nutritional support, and other. And after transplantation, good supportive treatment is also important. This is proper rehabilitation, lifestyle changes, psychological support, symptoms control, risk factors assessment, to assess risk factors of relapse, and if it's possible to prevent it. And of course, we need to control our patients during follow-up to assess physical reported and physician-reported MRI neurological assessment and patient-reported outcomes. So based on our result of a long-term follow-up for big group of patients, we can confirm that transplantation is safe and effective treatment for multiple sclerosis, not for only relapsing remitting variant, but for primary and secondary progressive variants. The best outcomes is when we provide transplantation in early stage as soon as possible. It's very important. And for today, fludarabine-based protocol is very promising with less toxicities. And also we don't stay on the one place. We develop a new lymphoablative conditioning. We try to combine transplantation to develop new approaches. Combine transplantation with cellular approaches. This is future. CAR-T therapy is also future. And because we work in multifunctional university hospital, we develop new approaches to early and late post-transplant rehabilitation together with our physiotherapy and rehabilitation departments. This is via virtual reality technologies, robotic technologies, which are very important for disabled patients. And of course, treatment modalities for patients who fail transplantation. This is second transplantation approach. And now is very important final part of my report. We receive lots of questions from different patients about prognosis, about possible effect and risks of transplantation. We have huge experience to answer all these questions. And question number one, how to assess prognosis if I make decision to have transplantation? I have never seen these results in other centers, so this is unique information. This is unique information. Now we develop prognostic groups and we publish our second step of prognosis during March-April conference in Florence in Italy in maybe 4 months. But for today we have that early transplantation, EDSS score less than 4, remitting variants of MS, absence of previous treatment, younger age, and better physical condition are very important factors. It doesn't mean that if patient doesn't have these factors, transplantation won't be successful. But what is the success rate we can calculate now? If patient has all factors, success rate is 95-100. Amazing results. Relapsing remitting multiple sclerosis with 1 and 2 factors, 90% success. Very aggressive variants like primary and secondary progressive multiple sclerosis without factors, 70-75%. To compare with traditional treatment, which give us maximum 10%, this result is also amazing. But of course, this is statistic. All patient situations are very, very individual. And if patient with progressive variant of MS has some additional factors like 3, 4, 5, success rate is much better. But of course, as I told you, this is statistic. And situation can be individual, and we can improve this statistic on individual level. Positive motivation, willpower, energy in proper rehabilitation, good organization of rehabilitation after transplantation, lifestyle changes can improve the statistic from here to here. This is the ideas for other future developments, and this is the idea to go ahead with this treatment. And second very important question, how can we help for patients with high disability level. Unfortunately, we didn't provide this transplantation in August and September for some very disabled patients with very long advanced disease. So it stimulated us to develop new approach how to help these people. And what is the most interesting here, I think we are starting our new transplantation protocol for patients with disability level more than 6.5. Previously, we refused for this group of patients because we are not sure that this treatment, traditional transplantation protocol, will be safe. But now we develop new protocol, and we consider this protocol will be completely safe for patients with high disability level. On the other hand, not less effective. What we can see here, we decrease systemic chemotherapy, protecting patients from serious side effects. On the other hand, we increase local immunosuppression given intrathecal chemotherapy and increasing twice the dose of monoclonal antibodies, not one but twice here, and additional chemotherapy through the lumbar spine punctures. We send chemotherapy in central nervous system. And of course, we follow this program, proper rehabilitation from the beginning to the end of this treatment, and recommendation to do it at home. So let's try, but I think this protocol will be very, very good option for advanced multiple sclerosis. Actually, it will be safe. And very important topic 3 is what should I do if HSCT didn't help me? Unfortunately, it's possible. We give very good result. We give very good statistic. We motivate our patients to think about 100% of success, but some patients relapsed. Firstly, we need to prevent risk factors. If patient smokes, stop smoking, follow healthy lifestyle, use healthy diet, use vitamin supplements, and of course proper rehabilitation. Lots of approaches, psychological lifestyles to decrease risk of relapse. But if it happens, we need to help. And we develop some programs for this group of patients. This is second transplantation options. And of course, if we give second transplantation after first one, we give another chemotherapy. And we provide additional intensification using intrathecal chemotherapy. This is chemotherapy like for advanced group through the lumbar punctures to increase intensity of this approach, keeping safety.